Thanks so much, Neha, and thanks everyone for coming in person, and for those of you online, thank you, Dr. Marin and the Grand Rounds Organizing Committee for inviting me to speak today. So as you can see, I will be talking about chronic aortic regurgitation, classifying severity, LV remodeling, and timing of intervention. Does one size fit all? I have no disclosures. So just as a way of an outline, we'll start off by talking about the pathophysiology and natural history of aortic regurgitation. Briefly, we'll cover the 2020 valve guidelines, some novel cardiac MRI data, talk a little bit about precision medicine, implications for valve morphology in terms of timing of intervention. And then as an ACHD doctor, you don't get away without me talking about a little bit of ACHD. So we'll talk about conotruncal defects and then some future directions towards the end. So here are my learning objectives. So first and foremost, we want to know the updated ACC AHA 2020 valve guidelines and their recommendation for intervention in chronic severe aortic regurgitation. Know novel CMR-proposed LV volumetric cut points for LV remodeling that warrants intervention, and then skill to decide when to utilize cardiac MRI for adjunct imaging data in chronic aortic regurgitation. So we'll start off just by looking at some cases from our group's practice, just to get you thinking about how you'd manage these patients and what kind of data you would like. So on the left, you can see a patient with a trileaflet aortic valve. This is 4D flow cardiac MRI, seeing the aortic regurgitation. Here's a patient with a bicuspid aortic valve with streamlines showing the regurgitation back into the ventricle. And then a patient with DTGA whose status post-arterial switch, who has an eccentric jet of aortic regurgitation. You can see that all these patients are reporting to be asymptomatic, preserved LVEF, and an end-systolic dimension that is less than 50. So now that hopefully I warmed up your brains, got you thinking a little bit about how to manage them, we'll dive into a little bit of the pathophysiology and natural history. I stole this side from my friends at Cardio Nerds because I think it's a good resource. If you don't know Cardio Nerds, check it out. So just as a reminder, aortic regurgitation is a volume and a pressure loading lesion. And so early on, and ignore the top right, we're just going to be talking about chronic, not acute aortic regurgitation. So in the top left, we see that there's mild aortic regurgitation without significant regurgitant volume and without significant LV volume or pressure. Over time, here in the bottom left, we see that chronic aortic regurgitation leads to increased wall shear stress. And then the LV tries to compensate by spherical remodeling. So we elongate and dilate and form a sphere to abide by Laplace's law to reduce wall shear stress and try to achieve this spherical remodeling. Over time, there's systolic hypertension and reduced aortic elastance. And then that Venturi effect impacts the coronary perfusion. And if aortic regurgitation proceeds and is unchecked, then eventually we get LV fibrosis, decrement, LV systolic function, and symptoms, right? And so everyone remembers this slide, I believe, this is a classic slide from Rick Nishimura and Mayo from medical school days, that, historically we were intervening on this steeper part of the curve when patients have symptoms. And over time, we've moved forward in terms of intervening more at this flat part of the curve when the LV starts to dilate. So my clinical mentor in medical school, Rick Lang, always taught us that for regurgitant lesions, we go for size, not symptoms. So we intervene earlier as the LV starts to remodel. So what does our natural history data show us? And so the historical natural history data, you see three big studies with echo in mode here, looking at chronic aortic regurgitation and progression. And so fortunately, aortic regurgitation progresses slowly to death with only 4% per year progression to an event rate in these studies. And many of the patients can be picked up with symptoms over time as we watch them, but a small portion do succumb to death or have asymptomatic LV dysfunction with an LVF less than 50%, during that period of medical monitoring. And so we're missing some of the patients, even in these historical studies, that develop more complications over time. But that was a group of patients with a median age of 39. And so our more modern era data is an older cohort with aortic regurgitation, not that younger cohort. And the rate of progression is more rapid than what we've historically been taught. So you can see this is data from Mayo. This is a study that was published in JACC in 2019, looks at AHA stage B aortic regurgitation, so those with mild to moderate or moderate aortic regurgitation. The vast majority of patients had mild or mild to moderate aortic regurgitation. And you can see that the 10-year incidence of moderate to severe aortic regurgitation progressed over time, with surgery happening in 1 out of 6 patients within 10 years. So again, patients all with less than moderate or moderate aortic regurgitation, 1 in 6 end up requiring AVR within the next decade. And the predictors of progression from this study were, interestingly, not hypertension, not the systolic blood pressure, but instead the aortic annulus and the STJ dilation, as well as the baseline aortic regurgitation. So the size of the aorta, as well as the degree of aortic regurgitation that you start with, is a good predictor of where you'll progress. So for all of our interventions in cardiology, we look at the tools that we have, and our excitement is predicated on what kind of non-invasive and invasive tools we have to intervene. And so if TAVR was a good option in aortic regurgitation, that would be great news for us. But unfortunately, we've had issues with valve migration and embolization with TAVR. We have issues with anchoring if there's not a lot of calcification of the valve. And so a lot of our studies so far using TAVR have not had great success. And that's why the guidelines give it a class 3 harm, except for those patients who are too high risk to undergo surgery, where it's more of an off-label use. So our tried and true intervention for chronic aortic regurgitation is SAVR, as we all know, surgical AVR. And you can see in the United States, about 13,000 patients per year referred for SAVR. Fortunately, the outcomes are very good. So you can see here that only 1% operative mortality in this group. But what I'd like to draw your attention to is down here in the bottom left, we're referring pretty late. So we're referring for class 1 indications for symptoms in over half the patients. And a quarter of the patients already have reduced ejection fraction at the time of AVR. We know that these patients with reduced ejection fraction have worse outcomes after AVR. So a quarter of the patients are referred when they're going to have a worse outcome after their surgery. So if I can give you a quick summary of the new modified natural history of aortic regurgitation, integrating some of this more modern data, we have an older population. So not that median age of 39, but a median age in the 60s of our patients who have aortic regurgitation in the United States now. They have a higher degree of comorbidities, and there's a more rapid disease progression than what we were historically taught. There are really limited therapeutic interventions, unfortunately, so our armamentarium is a little bit small in terms of what we can do to intervene. And obviously that curbs a little bit of the enthusiasm for aggressive intervention. And so my ACHD colleagues in the audience know that for our pediatric patients, and for younger patients, we often do have to intervene when patients are asymptomatic and won't derive a symptom benefit from intervention, but we do that in order to preserve longitudinal function of the ventricle. Fortunately, surgery does have good outcomes data, so only 1% mortality, as I mentioned. But in the patients who are symptomatic, and again, that was over half these patients that had a class 1 indication and were symptomatic, there's a 2.3 times increased risk of mortality after surgery. And so we're sending later when there's a higher risk. And like I said, a quarter of them already had reduced ejection fraction. So how do we decide when to intervene? And so I think this is really a philosophical question. And it depends if you're a Tolstoy believer or if you're a Shakespeare believer, right? And so if you're in the Tolstoy camp, you maybe fall on this line, that they must understand that we can only lose by taking the offensive. Patience and time are my warriors, my champions. Now, I love Russian literature, but I think I fall more in the Shakespeare camp. Better 3 hours too soon than a minute too late. And so hopefully by the end of the talk, you'll figure out which you are for chronic aortic regurgitation, more of a Shakespeare or a Tolstoy sort of approach. So that was a quick overview of the natural history and pathophysiology of aortic regurgitation. Now I want to go to the 2020 valve guidelines. For the fellows in the room, I won't belabor this because I know George does a great job with his lecture on aortic regurgitation, going through our qualitative, semi-quantitative, and quantitative metrics for aortic regurgitation by echocardiography. And then I just have a representative image here attaining the LV in systolic dimension, so where we make the measurement in this two-dimensional measurement for LV remodeling. So echo is our workhorse for chronic aortic regurgitation. We do have some limitations for eccentric or multiple jets that limit the quantification of aortic regurgitation. But you can see our classification for severe aortic regurgitation are these echo metrics here. It's jet width more than 65%, the vena contracta more than 0.6, the regurgitant volume, you can see here more than 60, and regurgitant fraction more than 50, EROA more than 0.3. And you know, we can classify patients based on their AHA stage as stage C1, so those that have a preserved EF and don't yet have significant LV remodeling based on this LV in systolic dimension, less than 50. Those who are starting to have LV decrement and systolic function, and then those with symptoms. And so as a kind of nice visual summary of this, we have what I like to call the 55-50 rule. So when I was taught in medical school by Rick Lang, this was the 50-50 rule. And so we've evolved a little bit towards being more aggressive with an EF less than 55% as an indication for intervention. So you can see patients with severe aortic regurgitation who are symptomatic get a class 1 indication. Again, those patients who are symptomatic are going to have higher risk after AVR. But that's our class 1 indication. As your LVEF is less than 55%, we get a class 1 indication if you're undergoing other cardiac surgery. And then for patients who are starting to have LV remodeling, defined by an in-systolic dimension more than 50 or indexed more than 25, we have a 2A indication. And then if we have progressive dilatation over time, we have a weaker recommendation if they're low surgical risk to intervene. And so these data are all from our old natural history studies that used in-mode echo as the metric to make these measurements, and then were later validated using more modern techniques. And these have really been in the guidelines, both European and American, since 1998, without much significant change. And a lot of that is because we haven't had volumetric-based outcome studies to really move the needle in terms of what we're using. So how do these guidelines perform? How do we do when a patient, when we wait for a patient to have symptoms? Well, you can see here that in the asymptomatic patients in the blue line, they do a lot better when we refer them to surgery, as opposed to the patients who have already started to have symptoms or who have class 3 or class 4 symptoms. So this was a total of over 350 patients who were undergoing surgical correction of their severe aortic regurgitation. And you can see that really symptoms we're already able to differentiate how people do after AVR based on symptoms. And so this study really helped us kind of look at an LVF less than 55%, and they proposed an in-systolic dimension index more than 20 as when we start to see a differentiation in those two curves. Here's another study from JAMA Cardiology, similarly showing us that our current guidelines in terms of the EF may be a little bit conservative. So you can see this restricted spline curve here that we really start to have incremental risk starting around 60% LVF, and that continues to climb throughout LVFs in the 50s and then as we go lower. And again, the insystolic dimension, we can see that if we index that to the body surface area, that our risk starts to go up at 20. So in this 20 to 25 range, we're already seeing incremental risk as opposed to the guideline cutoff of 25. All of these studies are older patients, predominantly male, and so there are some limitations there. So do we have volumetric-based data to guide us? We make these geometric assumptions. We know that not all aortic regurgitation remodeling is the same in terms of the geometry assumed. So what volumetric data exists? And so I'll get to that with 3 cardiac MRI studies, but before I do, for those of you who aren't as familiar with cardiac MRI, we don't make any geometric assumptions. We're able to have gold standard volumes and function by a 3-dimensional analysis. We're able to quantify multiple jets or eccentric jets. There's superior reproducibility of the regurgitant fraction, regurgitant volume, holodiastolic flow reversal in the descending aorta compared to echocardiography between readers. And we're able to look at other things like ventricular arterial interactions, the size of the aorta, as well as tissue characterization of the LV. So how is the LV handling that pressure and volume load over time? And so how do we do it? Well, this is historically how we've done it with 2D phase contrast imaging. We draw a line perpendicular to the flow in the vessel, and then we're able to directly quantify the forward flow through the valve, and then the regurgitant volume with an area under the curve. So we get a direct aortic regurgitant volume as well as a regurgitant fraction in order to quantify the severity. And so this is what you get at the end of the day with the cardiac MRI, volumetric analysis telling you biventricular size and function. You can look at global longitudinal strain, see your aortic regurgitation as you see here, and then tissue characterization, we can see early markers of interstitial fibrosis with ECV, and there's data that more than 24% has incremental prognostic value, or replacement fibrosis, so scar tissue that is permanent of the ventricle with LGE imaging. So it's not perfect though. Our cardiac MRI valve cutoffs were completely derived from echocardiography. So we never came up with our own cut points by cardiac MRI. We just stole them from echocardiography. And so you can see here the echo quantification in the top left that I put, it mirrors exactly our cardiac MRI cutoffs. And so these studies that I'm going to go through now try to push the needle lower in terms of what the threshold should be as we look at outcomes for patients, rather than trying to make the 2 modalities perfectly concordant. So, really, a lot of my focus, I want to be in these patients that are stage C1, right? So they have preserved ejection fraction, they're starting to have LV remodeling, but we're trying to decide when to intervene and what things can really sway us in one direction or the other. So I'll start off with a study that was published in JACC Cardiovascular Imaging out of Vienna. This was a study of 232 patients with varying degrees of aortic regurgitation, and they all had an echo and a cardiac MRI within 1 month of each other. The mean age was 55 years old, and 35% of the patients were female. And they defined severe aortic regurgitation by holodiastolic flow reversal in the descending aorta, and looked at a composite outcome of heart failure hospitalization or cardiovascular death at a median follow-up of about 3 years. So this is how they looked at holodiastolic flow reversal. You can draw a region of interest around the descending thoracic aorta and see the flow over time and the velocity over time to see that there's flow reversal. So just from our standard 2D phase contrast imaging, convenient data that we can collect at that same time. And so as we look at this population, you can see that similarities between the patients with holodiastolic flow reversal, what they define as severe aortic regurgitation, and without, in terms of some of their baseline characteristics, except for their sex. And then down here, you can see, except for NT-proBNP the hematocrit as well. But what I wanted to draw your attention to here at the bottom is that this was real-world study. So some of these patients had prosthetic valves, some had Ross procedure before, some had an arterial switch, not the majority, and a good number had atrial fibrillation. So my cardiac MRI colleagues over here know that that can be the bane of our existence for some of these studies with trying the ECG gate, and that just like echocardiography, we can struggle with our quantification in the setting of atrial fibrillation. And so what did they find? Well, they found that the patients who had holodiastolic flow reversal had significant LV remodeling. And so you see, sorry, the mouse is a little hyperactive here, had lower LVEF, had much higher LV and diastolic volumes, right? And had much more significant regurgitant volume and regurgitant fraction. So 48% regurgitant volume, regurgitant fraction of 39% in comparison to 6% in the group without holodiastolic flow reversal. So we picked a good metric for severe aortic regurgitation. And if we look at our AUC curve here, the regurgitant fraction that had the best sensitivity for holodiastolic flow reversal was much lower than that 50 cut point if we extrapolated from echo. It was 27 in this study. So maybe our MRI threshold should be MRI specific, not derived from echocardiography. And that's what I wanted to use this study to really drive home that point, as well as that holodiastolic flow reversal in our thoracic aorta can be a good marker of the severity of aortic regurgitation. And so you see here that in the patients who had holodiastolic flow reversal, that independently associated with a 2.8 times increased risk of cardiovascular death or heart failure hospitalization. So this happens again and again, and it sometimes surprises us in clinical practice, but it shouldn't surprise you. These modalities are looking at different things, different ways. And so while they are often used in a complementary fashion, they're not often concordant, right? And so we can reclassify patients who have moderate to severe aortic regurgitation on echocardiography into non-significant AR or more significant. We're fairly concordant in terms of those who have mild or mild to moderate AR, right? With only a small percentage that get reclassified. But in those who are called severe on echocardiography, you see that a not insignificant number are down classified with cardiac MRI. And we see that in the mitral regurgitation space. We see that in the aortic regurgitation space here. So moving on to another cardiac MRI study. This is out of Minneapolis Heart Institute. This was published in JAMA Cardiology just a couple of years ago. And they looked at patients undergoing cardiac MRI and echo within 90 days of each other, and looked at 178 patients with more than moderate aortic regurgitation on echocardiography. They excluded those who had acute AR from dissection, poor windows, prior AVR, infiltrative cardiomyopathy, or severe concomitant valvular disease. And their cohort was 67% male, the vast majority minimally symptomatic, so 88% New York Heart Association class 1 or 2, and about 40% of the patients had bicuspid aortic valve. In this study, the primary endpoint was death, heart failure hospitalization, or progression in New York Heart Association class, and they censored patients at time of AVR with a median follow-up very similar, about 3 years. So I know table 1 shows up very small. Suffice it to say that there are differences on echocardiography in the insystolic dimension and the LVF that differentiates patients with symptoms. And then at the bottom, you can see a lot of cardiac MRI differences and being able to distinguish patients who are symptomatic versus not. And looking at their penalized cubic spline curves, you can see that there are different thresholds that they propose depending on our modality with echocardiography here on the top, and I'll just focus your attention on the bottom to cardiac MRI. So an LV end diastolic volume index around 108, an LV end systolic volume index more than 45, which conveniently is the ACC and the ACVI's threshold, and sorry, ASE and the ACVI's threshold for severe LV remodeling. And then an aortic regurgitation fraction of more than 32%. So once again, the MRI-specific threshold for severity is probably lower than that 50% that we have on echo. And so there's probably a modality-specific threshold that we should be using. And if you dichotomize this and look at patients who have significant LV remodeling by cardiac MRI with an end systolic volume index more than 45 versus those who do not, you can see a separation in the Kaplan-Meier curves very nicely. And that actually holds true for echocardiography as well. But you see that our current guideline threshold of 25 is not so good in terms of differentiating these patients, whereas we really start to pick it up at an earlier, like we saw in that earlier echo study out of Mayo, at 20 for our end systolic dimension indexed. So now we have a couple studies that give us volumetric cut points that help us to see that we can use 3D volumes as a way to see LV remodeling and chronic aortic regurgitation. And so this was a study that came out last year that I think is helpful as a multi-center study, almost 500 patients published by the group at Houston Methodist. Their median age was 60 years old. So again, different than our natural history studies historically, much younger patient population there. And this is a much older patient population. They all had asymptomatic, moderate to severe aortic regurgitation on cardiac MRI with a preserved EF. And they looked at the development of symptoms, reduced LVF less than 50 using the old 2014 guidelines, or a guideline indication for surgery or death under medical management. And so you can see, once again, I'll kind of skip over our table one in terms of those who did or didn't have a composite outcome. There's discrepancies in terms of the LV remodeling, not surprisingly, with those who have a MACE event having much more LV remodeling. And this, again, was a real-world study of patients that had, problematic cardiac MRIs because of atrial fibrillation. And you can see that the aortic regurgitation severity is markedly different between the two groups. And by echocardiography, the majority of patients kind of fit into this moderate AR severity on their echo. And so when we look at the receiver operating curves and AUC here for what our optimal threshold should be, you can see a regurgitant volume more than 47 mL, so lower than the echo cutoff of 60, a regurgitant fraction more than 43, so a little higher than the other two studies, but lower than our echo cutoff. And then an end systolic dimension indexed more than 2, and an end systolic volume indexed more than 43. So again, right at that 45 threshold that we've now seen from echo and from multiple cardiac MRI studies. So we do have outcomes-based data now with volumetric remodeling. And so their central illustration, to summarize this, just shows us that, a regurgitant fraction more than 43%, an end systolic volume index more than 43 are really the optimal thresholds to look at clinically significant outcomes in this patient group. So what about tissue characterization? Can we have additive prognostic information from our cardiac MRI in terms of characterizing the tissue? And the short answer is yes. So when we look at LGE in patients who underwent cardiac MRI for aortic regurgitation, we can see that about a third of patients have some LGE, and that in multivariable analysis, that scar was independently associated with death with a hazard ratio of 2.5. And so, even in those patients, as you can see here in the top left, survival was discrepant between those without scar in the blue line and those with scar. And then in the top right, You can see that we have, for non-infarction pattern scar, a little bit better survival than those with prior infarction. And that scar, again, was a strong predictor of death. But even those patients who have scar, is it just non-intervenable, is the question, right? Well, it is modifiable. So those who undergo AVR with scar have much better prognostic outcome than those who don't and are watchfully weighted here in the, so if you have aortic regurgitation, don't undergo AVR and have significant scar, you have the worst survival of all these groups. So where does that put us in terms of the gray zone? And so I'll just kind of pause here for you to look at this. I think we have this category of patients who are having LV remodeling, who have an insystolic dimension index in this 20 to 25 range, have an EF that's preserved, maybe don't have symptoms yet, maybe we haven't put them on a treadmill to prove that yet, but they aren't reporting any symptoms. So how can we follow them? And hopefully I've shown you enough data to convince you that we can, more accurately quantify the degree of aortic regurgitation by cardiac MRI. We can use cut points that are lower than the guidelines and around the low 30s. We can use holodiastolic flow reversal. We can use tissue characterization, like an ECV more than 24 or LGE, as imaging biomarkers to suggest that the patient is higher risk and maybe is a patient that you want to consider for earlier intervention. And biomarkers as well. You can use NT-proBNP, not all MRI. So this is, I thought, a nice kind of summary from a nice review last year that was published in JACC that summarizes that. So with cardiac MRI, really the patients who have an LVF more than 60, insystolic volume index less than 45, those are patients you feel very reassured about, that you can continue to serially monitor. We're not so worried about earlier intervention in that patient group. And in this gray zone, in patients, here's our guideline indications in the top here, but in the gray zone, we can use some of these additive imaging prognostic markers to decide who to intervene on earlier. All right, so I've hopefully not bored you too much with our cardiac MRI data. So I want to switch gears and talk a little bit about precision medicine and how this differs among patient groups. And so there are a number of factors that influence our outcomes after AVR: our age, our sex, whether we have an underlying restrictive cardiomyopathy, that if we've had prior valve intervention. But I would like to focus just on female sex and what we know about females with chronic aortic regurgitation. So you can see this is data from Sweden. Valvular heart disease is fairly equally prevalent between the two genders, but not so much in terms of aortic regurgitation, right? So there's a 3-to-1 male to female predominance of bicuspid aortic valve, and bicuspid aortic valve is our most common congenital heart defect. And so because of that, we see a predominance of males that have chronic aortic regurgitation more so than females, as you see here, this blue bar compared to the females in pink. And so because of that, aortic regurgitation is less prevalent in females because there's less bicuspid aortic valves. And females have smaller volumes and smaller LV mass, but earlier symptoms compared to males, and are diagnosed often at a later age, at a later disease state as well in terms of symptoms, and then are referred later for surgical intervention. And the sad thing is we've known this for 30 years. So this is 1996, I believe. And the 10-year survival for men was 72%, and for women, 39%. So where have we come in 30 years in terms of understanding this? Well, unfortunately, not that far. But recently, there was a nice study that was published. This was by Debbie Kwan at Cleveland Clinic that looked at 243 patients with more than moderate aortic regurgitation on echo, who underwent an echo and an MRI within 90 days of each other. And it had a larger predominance of women than in some of these other studies to help us understand this. And women demonstrated Smaller end diastolic volume index, so 97 compared to 126 in men. Smaller LV end systolic volume index, 41 versus 55, and blunted LV dilatation despite having symptoms sooner than men. And you can see that the reason for this is that women achieve this kind of what's considered earlier remodeling before we achieve Laplace's law and reduce wall shear stress, this conical remodeling, and are less able to achieve spherical remodeling to reduce the wall shear stress. And so we get less of the globular elongated ventricle in women and symptoms earlier because of this. And so maybe we should have some sex-specific thresholds, not just MRI-specific, but sex-specific thresholds for when to intervene to move the needle in terms of outcomes for males versus females. So some would argue that as a woman with chronic severe aortic regurgitation, you get nothing if you wait for it. All right, good. We have some Hamilton fans in the audience. Now I just want to talk a little bit about, I just wanted to summarize after 40 years, and I think Robert Bono has, published a lot of the early data and echocardiography by M-mode, and so I trust his words more than my own to convince you that, as he says, the real issue is why, after 40 years, decisions are still being made on linear measurements of the LV size. And given the recent advances in cardiac imaging, it is time to evolve to measurements of true LV volumes as the clinical standard, rather than relying on the surrogates of LV diameters. And I think that can change the needle for women in particular, right? Where we're missing remodeling and we're missing earlier intervention as we have symptoms earlier than men. All right, so what are the implications by valve morphology? Does it matter if you're bicuspid versus unicuspid versus trileaflet? So here's, just kind of an overview of our different aortic valve phenotypes that we can have. Here's a patient who has a bicuspid aortic valve, cardiac MRI, in the LV 3-chamber view, seeing this really eccentric jet directed at the anterior leaflet of the mitral valve here, with that black dephasing directed at that leaflet. Very significant LV remodeling, so we have more of this spherical dilated LV that's elongated with very high volumes, a very high stroke volume, but preserved ejection fraction. We use 2D phase contrast imaging, and we're able to directly quantify the amount of regurgitation, a horrific amount, 112 ml regurgitant volume, and that gives us a regurgitant fraction of 64%. Here's a nice en-face view of a Severe's type 1 valve with right and left fusion, and then a single raphe there that has the bicuspid fish mouth opening. So for these patients who have bicuspid aortic valve, where do we measure, and does it matter, and does that have any implications? And so the short answer is it does, and the reason for that is because, as you all know, about half of patients with bicuspid valves have bicuspid aortopathy and dilation of the aortic root or ascending aorta, and so we can have swirling of flow and underestimation of our regurgitant volumes and fraction depending on where we measure. And so you can see we can measure at the annular plane, at valve leaflets, at the STJ, at the ascending aorta, and get different phase contrast imaging. And where we measure really does matter, with more underestimation of flow in the ascending aorta. So why might that be in these patients? Well, it's related to non-laminar flow. So this is, Makoto, is for you. This is very nice data out of Tokyo that was modeling from bovine valves that looked at a trileaflet aortic valve has this very nice laminar flow, whereas bicuspid valves that are asymmetric in this middle row compared to symmetric have really eccentrically directed jets and swirling in the ascending aorta, as you can see in these three images here. And when we look at 4D flow streamlines, we're able to really visualize that even better where we can see these, what are called vertical rings of flow patterns in the ascending aorta, where the velocity is changing directions, and we can have superior, inferior kind of orientation of this swirling pattern that can falsely lower the aortic regurgitation that we see. So the morphology matters most in terms of aortopathy, associated aortopathy, and where we measure matters most. And so my critic and my colleagues know that the STJ is really our best level to make the measurements in patients who have non-laminar flow states. And so with that, I'll kind of progress gently into to ACHD domain. Hopefully, I saved it for the end, so hopefully you don't all fall asleep on me. With our conotruncal defects, and so these are patients with tetralogy, transposition, interrupted arch, double outlet right ventricle. We know that these patients, we know that these patients often have concomitant aortopathy. So in some studies, over 50% of patients with concomitant aortopathy, they very commonly have eccentric jets of aortic regurgitation, as you see here in this nice case report that our first-year fellow Desiree published. And so this is a patient with DTGA, arterial switch. We've switched the great arteries. We have lecompted PAs anterior to the aorta, draped over the aorta. And like one of the three main complications long-term of DTGA arterial switch, we see that there's aortic regurgitation, and it's a very eccentric jet, which would be difficult to do quantitative metrics on echocardiography. So with that in mind, our second-year ACHD fellow, I don't see her, Bryn, did some very nice work that I'll try to walk you through in just the next couple of minutes. So Bryn laboriously made measurements at the annulus, at the STJ, at the ascending aorta, and looked at different forward flows at these different levels. She looked at the regurgitant fraction based on phase contrast imaging and 4D flow at those different levels in almost 200 patients, and then directly quantified the regurgitant fraction and volume from tracing the regurgitant jet. As you can see, there's her tracing right there. And then we can do, just like our 2D phase contrast image, we can trace that volume over time and get a quantification of the regurgitation. And so this was a group of patients with moderate or complex congenital heart disease. About 40% had conotruncal defects, a good number with bicuspid aortic valve, some with Shone's, and then a mixture of other lesions. And really what we set out to do is to compare indirect versus direct methods of quantification of aortic regurgitation by 4D flow and understand where the best places to make these measurements were and which method corresponded best with the gold standard of LV volumetry. So we excluded patients that had concomitant valvular disease, concomitant shunts, or other things that may skew the data, so that we had a more accurate comparison. And then we wanted to know which aortic planes to make these measurements and then determine potential influence of common anatomic variations. And so you can see from our scatter plots here, on the left is our indirect methods, and then on the right is our direct methods. And so there was better agreement between direct quantification of regurgitant volume and fraction on 4D flow with LV volumetry than there was with our kind of our 2D phase contrast sort of analogous sort of measurements. And so, you know, with that, it seems that 4D flow, we ought to be making direct quantification of the jet as kind of a routine practice. And by that, we found that there were about a third of patients who had mild aortic regurgitation in this cohort, 39% who had moderate, and 27% who had severe. And I'll come back to that for the next part. But this is looking at subgroups, and I think what I want to stress here is that those who have aortic dilatation, that's really where the measurement matters the most, and where this helps the most, right? And so that's where we have the strongest correlation and the smallest mean difference between volumetry and the quantification is when we look at the STJ in patients who have a dilated ascending aorta, and that's because of those vertical rings, right? So we can underestimate flow because of this vertical helical pattern of flow in the ascending aorta when it's dilated. So I know that that's very MRI specific in terms of our measurements, but the next step of the project is to look at clinical outcomes in these patients, just like those other MRI studies that I alluded to. And so we're using the cardiac MRI-based criteria, so an EF less than 55%, or using that in-systolic volume index more than 45 as a cut point. And if you look at our population, 158 patients who had moderate or more aortic regurgitation, those thresholds are very good in terms of test characteristics of predicting adverse outcomes in this cohort. So sensitivity of almost 96%, specificity of 86%, very good negative predictive value. So if you don't have whole diastolic flow reversal, your in-systolic volume index is less than 45. See, in a couple of years, we'll keep monitoring. But if not, then your positive predictive value is still pretty good at 73%. And so what we found is that among our patients who underwent AVR, that all of them met these MRI criteria, whereas only a third of them would have met criteria by echo. And we look at those who were clinically monitored, 13 of them had heart failure, clinically significant arrhythmias, death, or transplant, and 85% of those would have been referred if you'd used MRI criteria, whereas only one would have been referred with our more historic echo criteria. So I think some provocative food for thought in terms of what we should use as our thresholds in both the general cardiology population as well as the ACHD population. So just a couple slides for future directions, and I think I'll leave a few minutes at the end for any questions or discussion. So this was the ALIGN-AR study was an investigational drug, an IDE study that was just published in the Lancet last month that looks at this new valve that's developed for aortic regurgitation in mind. So this is the Jenna Trilogy valve. I understand from Christian we're not using it here yet, but this is a kind of an early study that looked at 177 patients. And the primary outpoint, again, was a safety endpoint, but this valve seems to do fairly well. And so we're yet to see if we're kind of in the late 2000s, like aortic stenosis in the partner trial in 2009, right? If that's where we are with aortic regurgitation and transcatheter interventions, and if we'll see new technology kind of move the needle. I think there's still a lot to be seen whether or not that'll be the case. And then there are some ongoing studies that are looking at kind of a strategy based for early intervention using cardiac MRI to guide early intervention among patients who are demonstrating some of that gray zone type of remodeling that I think will be very interesting to see. All right, so to circle back to the learning objectives from the beginning, hopefully everyone now feels very updated with the 2020 valve guidelines and remembers our cut points, the 55-50 rule, so LVF less than 55, in systolic dimension more than 50, half that if you index it, typical BSA of 2, 25, right? But again, 20 starts to be the signal that we see that, so maybe a little bit earlier. Now, hopefully I've convinced you that we can do volumetric based cut points, not just these cut points that were derived from InMode 40 years ago, but a volumetric remodeling as a threshold of when to intervene in aortic regurgitation. So an in-systolic volume index more than 45, roughly, in 4 studies that I showed you. And then, hopefully for especially all the fellows in the audience, that we think of cardiac MRI as a tool to guide us in the gray zone to really look at some of these risk enhancers and imaging biomarkers of risk for our patients to decide whether or not to intervene earlier. And so coming back to our 3 cases from the beginning, I just ask you to ponder if there was more information that you wanted. I gave you very little information on these patients and what that would have done to change or sway your management for these patients. So are you Tolstoy or Shakespeare, right? Where do you land? So with that, I just wanted to thank everyone for your attention.